Good morning, I'm Luke Burnet, and I will be discussing the correlation of frozen section versus permanent section diagnosis in patients with suspected toxic epidermal necrolysis. See here my co-authors from the JMS Burn and Research Centers in Jackson, Mississippi and Augusta, Georgia. So IRB through IntegraView out of Austin, and I have no conflicts of interest. The toxic epidermal necrolysis. Clinically, skin reaction with erythema that you see here on the left, and with subcutaneous exfoliation that will usually start as blistering. You see here a more progressive blistering that leads to the subcutaneous exfoliation. Here, A, you see some oral mucosal ulcerations. B, you see how widespread it can be on the back, and then C and D, ocular manifestations of TENs. And here is what we want to avoid through early testing with the frozen section diagnosis is this full spread TENs leading to critical care stays. So Stevens-Johnson syndrome as opposed to toxic epidermal necrolysis, it's the same process pathologically, but by convention, Stevens-Johnson syndrome is less than 10% total body surface, with TENs being greater than 30%, and that 10 to 30% is TENs SJS overlap. Manifestations of the disease, again, rash and skin bulla that can lead to full thickness skin loss, dehydration leading to sepsis, conjunctivitis, bronchopneumonia, chronic obliterative bronchitis, esophageal ulceration and stricture, cholestasis and hepatocellular necrosis, oral mucosal ulcerations, as well as nasopharyngeal and epiglottal ulcerations. It can also affect the genital mucosa and can lead to acute renal failure. So Total Burn Care 5th edition defines toxic epidermal necrolysis as an immunologically mediated burn, a classic type 4 delayed hypersensitivity disorder, with pathologically seeing keratinocyte apoptosis and secondary epidermal necrosis with T-cell infiltrates. Triggers, the vast majority being medications, including but not limited to allopurinol, antibiotics, beta-lactams, including cephalosporins, carbapinams, and even penicillins, and sulfonamides, anticonvulsants, analgesics, and NSAIDs. And then viral illnesses, HIV patients are significantly at higher risk of getting TENs and has also been associated with the dengue virus. Mortality can be as high as 25%. So differential diagnosis, first erythema multiforme is really on that Stevens-Johnson syndrome TENs scale, with erythema multiforme being the early stages of the disease process. Bullous pemphigoid and pemphigoid vulgaris, autoimmune disorders affecting the skin as well. Lupus, another autoimmune disorder with propensity for mucosal ulcerations, and then other nonspecific drug reactions. So advantages of early diagnosis, first and foremost, would most of the time be discontinuation of trigger medications, initiation of resuscitation and wound management, consideration of transfer to a burn unit, and consideration of adjunctive treatments. And we have steroids, cyclosporin, and IVIG. And a big takeaway for early diagnosis being important, its accuracy, is that none of these treatments are themselves innocuous. So having an accurate diagnosis to start before you move forward is key. Again, diagnosis begins with the physical exam, just like anything else, with taking a good history, focusing specifically on medications, and then full thickness skin biopsy to confirm. Again, pathology shows keratinocyte necrosis with subepidermal separation. And a 2010 study by Osaka et al. Evaluated whether or not frozen section diagnosis could be made with TENs and Stevens-Johnson syndrome. And they concluded that although the frozen sections were of less quality, they could reveal the presence or absence of epidermal damage. Frozen section biopsy could be helpful for these diseases. So our study, between January 1st, 2015 and August 31st, 2018, 100 patients were referred to the JMS Burn Center in Augusta to be evaluated for TENOs. Of those 100 patients, 67 were deemed appropriate to move forward with skin biopsy. The biopsy technique uses a standard 2 millimeter punch instrument. The biopsy was taken from blistered tissue and rash sites where demarcated necrosis areas were avoided. Specimens were sent for frozen and permanent sections. The results, 52 sections were read as 10 positive, with one specimen later being changed to bullous pentacoid. So positive sections. 98% were positive or were consistent with the permanent, with a positive predictive value of 98%. 15 frozen sections were read as 10 negative, with 4 being 10s positive on permanent sections, a negative predictive value of 73%, which isn't as high as the positive predictive value, but of those diseases in the differential diagnosis, really only 10s can move forward with treatment with the frozen section diagnoses. All the rest of them have to have permanent section diagnosis to move forward. So characteristics of TENS pathology were consistent with our frozen and permanent sections. Here we have a frozen section demonstrating the keratinocyte necrosis across the top with that subepidermal separation there on the right, and then a permanent section demonstrating the same thing. We have that line of keratinocyte necrosis, and you can see the subepidermal separation there on the left. So for discussion, frozen section diagnosis was for TENS positive readings were consistent with the permanent sections in 98% of cases, with a turnaround time of 1 hour versus a day or days, depending on the pathologist that you're working with. Frozen section diagnosis can expedite transfer and treatment. Any questions?
Thank you.
My name is Laura Cooper. I'm a surgery resident doing research at the ISR with Dr. Chan. These are the standard disclaimers. I have no disclosures. This is our lab group. Dr. Chan is our PI. All of these people contributed to today's talk. So when we talk about skin grafts, burn injuries result in about 40,000 hospitalizations in the U.S. each year. Skin grafting is one of the most common procedures that surgeons do, and we know that grafts fail anywhere in a range from 7 to 15%. Failure can be due to infection, hematoma, seroma, or necrosis, but the most common cause of failure is actually an inadequately vascularized wound bed. So when we think of successful graft take, we know the stages involve imbibition with diffusion of nutrients to the wound bed, and then enosculation, and then finally vascularization when we have skin graft take. But what happens when we don't have graft take? So we have a patient like this that comes in. We can see exposed joint, I don't know if I can do that, joint and tendon. And so how do we get coverage on this wound? For this patient, we actually did a gastrocnemius flap to cover the joint, but we still had the tendon exposed. The current options are really to cover that tendon with a dermal substitute and then bring the patient back at a later date for grafting. The problem with that is, we leave a patient with an open wound for a longer period of time. They have multiple procedures. So we wanted to figure out how can we make this a single stage procedure? How can we bring this patient in for one operation and do it all at one time? Or this patient, again, a relatively clean wound, but I think we would all agree that this is not ready to be grafted today. So again, we wanted to kind of bridge that gap. How can we get to this point where we can graft both of these wounds today and we know the grafts will take? So our idea to do that, because both of these wounds really have the same problem, the wound bed isn't ready, it's not vascular enough. at this time. So how can we get to the point that we can support the graft until the wound bed is vascular enough to actually support the graft itself? Our idea was almost to extend the imbibition period, to apply topical exogenous nutrients and oxygen to support the graft until the wound bed can actually support the graft itself. So to do this, we wanted to create a reproducible, poorly vascularized porcine wound bed model. We can't necessarily dissect down to tendon and bone that are poorly vascularized, as you saw in that first picture, on all the pigs. And so to do this, we decided to use acellular dermal substitutes. And then we wanted to decide the thickness of the dermal substitutes, because we know if we put down a really thin dermal substitute, the skin graft is pretty much going to heal like normal. If we put down a really thick dermal substitute, then the wound bed won't be able to vascularize through, and you'll have complete graft failure. So to do this, we created 10 excisional wounds on the dorsum of a porcine model. If we take a closer look at the wounds themselves, each wound we laid down a varying depth of the acellular dermal substitute from 0.4 millimeters to 1.6 millimeters. And then we placed the skin grafts on top. We placed a wound vac on the pig for 7 days and then reassessed again at 14 days. We did both a vac alone and a vac with normal saline instill, just to see if the instill with the moisture would improve graft take in and of itself. So on this slide, you can see the wounds with just the vac alone on the right-hand side, upper corner. And then the bottom 10 pictures are the normal saline instill in addition to the vac. And what we saw when we looked at the actual wounds themselves, the dark blue grafts are the normal saline instill, and the light blue are the vac alone, that up to 0.8 millimeters had an increase in graft take with the normal saline instill. And we actually saw that with the 0.8 millimeter thickness, we saw a significant improvement with the normal saline instill alone, and those wounds are highlighted in the red. So we decided to go with a 0.8 millimeter dermal thickness, but then we needed to determine what we would use for our topical exogenous nutrient supplementation. So to do this, we took skin grafts from the backs of recently deceased porcine models. We took biopsies of those grafts and then put these in cell culture. We included the listed media with their components listed as well. And then we took a look at the cell cultures. We wanted to see the number of dividing cells and the number of dying cells to see which media was really performing the best and that we could use as topical nutrients. To look at the dividing cells, we looked at lactic acid and enzymatic carbonate, which are both markers of high metabolism, dividing cells, and a media that would be successful. We saw that the DMEM and the Williams E had the highest number or highest amount of lactic acid and enzymatic carbonate produced, thereby the most metabolism, the most dividing cells. To look at dying cells, we looked at the lactate dehydrogenase activity, and we can see that the Williams E had the least amount of lactate dehydrogenase activity, i.e. the least amount of dying cells. So to decide between the DMEM and the Williams E, we looked at the amount of glucose consumption, and you can see here that the DMEM with the high glucose had the most glucose consumption. But when we took a closer look, the dark blue graphs are the amount of glucose that's in the starting media, and the light blue are the amount that was consumed. And we could see that the DMEM with the high glucose actually had much more glucose than was consumed, indicating that maybe there was too much glucose in that solution. We didn't want a lot of extra glucose not being used in the media and being able to serve as a nidus for infection, for example. So we decided to go with the Williams E. So what does this mean? Using acellular dermal substitutes, we've been able to create an accurate, reliable, poorly vascularized wound bed model. Based on our data thus far, normal saline instill vac treatments help improve graft take. And we're currently conducting experiments on the use of Williams E instill as topical nutrient supplementation. What's next is that we're again conducting these experiments currently. We hope to look for improvement in graft take with the addition of exogenous oxygen in the future. And we'd like to assess which roles each of these individual additions play, whether it's the moisture, the exogenous nutrients, or the exogenous oxygen in the approval of skin graft take. These are the people I'd like to acknowledge, and I'll take any questions.
First, I'd like to say thank you for the opportunity. Me as an undergraduate student, I'm really honored to be here in this conference, so thank you to the program committee for the opportunity. This is what I'll be presenting today. Thank you. The authors have no commercial interest to disclose. Hurricanes present a unique challenge for disaster preparedness. This is an anticipated event, but the effects last an unspecified amount of time, while power outages and thus the need for generators, candles, and dependence on gas cooking continue. Hurricane season 2017 was a really historical one for us in Puerto Rico. Hurricane season in Puerto Rico starts the 1st of June and ends the 30th of November. This is 6 months where we're under threat of hurricanes and disasters such as this one. During Hurricane Maria, the island experienced steady winds of 150 miles per hour and wind gusts of 180 miles per hour. We documented our experience before, during, and after both hurricanes. Some of you may have seen pictures of the effects that the Hurricane Maria left on the island, and here are some examples of what it did to our infrastructure, our transportation, and our housing, and our electrical system. Here are some pictures of flooding that occurred during the hurricane. Some might not know that 2 weeks after the hurricanes, a strong depression fell on the island, and flooding occurred over already saturated and fragile terrain, which delayed recovery efforts. Here are some more pictures of the extreme damages that the electrical system faced, where the power cables had completely fallen and solar power farms were completely destroyed. The island was immediately after the Hurricane Maria 100% without power. The small percentage of the population that did regain power was extremely inconsistent and fragile because they were suffered with frequent outages. And here are some pictures that NASA took early 2017, and the picture down is a picture of Puerto Rico a couple of weeks after the hurricane. The hospital has a disaster plan, but it's really non-specific and non-descriptive. And here I'll quickly discuss the 4-phase emergency plan. The first is prevention and mitigation. We identify potential risk and establish means for prevention and mitigation. Preparation. The inventory will be revised and necessary emergency equipment will be checked so it functions adequately, and the staff will be reoriented about the hurricane emergency plan, which is this 4-phase emergency plan that I'm right now presenting. And response, all emergency plans will be activated and carried out accordingly. This doesn't say anything about what the emergency plan really is and how it will be carried out. All activities, such as recovery, all activities that can be reestablished will be once the emergency is over, and all staff will work together to reestablish the normal working operations as soon as possible. Additional complications, we didn't have an organized burn center before 2010, and there was no pre-established center for burn patients to arrive to in an emergency such as the one we faced in 2017. And there was no statistics on what would happen, so there was no means to prepare us for what was to come. And our plan consisted of transferring patients to the university hospital. Materials were used up quickly immediately after the pass of Hurricane Irma, and a huge order for materials was put in place to stock up for the upcoming weeks. We coordinated with distributors to have materials stocked locally. Patients arrived from St. Thomas, St. John's, and Tortola, the islands in the Caribbean, and with an overflow unit of about 26 patients, the second hurricane was announced. Our burn director tried to activate the Southern Region Burn Disaster Plan, but the CFO revoked his privilege. Our response to this was that we doubled the number of our nurses by integrating nurses from other units, and the nurses teams were rearranged, where we paired experienced burn nurses with unexperienced ones. Also, we coordinated with the military to transfer patients, bypassing the usual call ahead to present each patient procedure. The nurse manager was authorized to place orders for materials without having to pass through the normal protocol. Here I'll talk about the pattern that we saw of emissions. It is important to note that this pattern was seen in both hurricanes, and we had a recent hurricane this year, threat of hurricane, and we saw the same pattern, where patients were admitted steadily, 1 to 2 patients a day, up to 48 hours prior to the hurricane where the warning was announced, and then no patients were admitted or were in the ER. And then we didn't see patients until after the roads were cleared and transportation could be reestablished. How the patient burn pattern changed. The patient admissions doubled from 32 patients a month to 65 patients a month, and the total burn body surface area quadrupled from 14.6% to 19.8%. Although to pediatric radios changed from 63.33 to 85.15, which is, in light of this, a positive note because the pediatric population was not really the one affected during this disaster. The majority of the burns were deep ones that needed autografts, and the pattern persisted until the power was restored 5 months after the hurricanes. The common reasons for burns were gasoline, inadequate storage, handling, and use of the gasoline. Most people didn't have experience with gas cooking or cooking over charcoal or wood, and candles were often used to light up the houses that had no generators. Lack of size D batteries led to the use of open flame candles. And people filled up their generators with gasoline and had a candle right next to it. So these flames were very frequent. Here are examples of the inadequate storage of gasoline. They used water containers and filled up gasoline there. What did we learn? It is extremely important to have an inventory of materials on the island in case of emergencies. The hospital credit card must be liberated for our use in such extreme cases as the one we faced. In the face of poor access to communication, it is extremely important to have good working relationship with first responders, military, and the emergency department. It is not as important to have all hands on deck during the catastrophic event, as it is more important to have the highly trained staff rested and serve as leaders after the hurricane passed, after the emergency has passed. Conclusion, there is no escaping a disaster like this once it is announced. Hurricanes have always been a threat and will continue to be so to our island. It is our responsibility to learn from the mistakes made and adopt the changes that did us good. It is this way we'll be the most prepared when another emergency is announced. And I want to do a special thank you, because throughout the emergency, the military brought multiple burn OR bundles, dressings, and other materials donated from anonymous burn centers. And to those centers, we say thank you.
Thank you for that introduction, and thank you for having me. So I would just like to acknowledge everyone who assisted me in this project, names of which are listed here on the slide. And for this presentation, I have no relevant financial relations to disclose.
So many of us are aware that patients in the hospital are at an increased risk for developing a venous thromboembolism, or VTE, as I'll refer to it throughout the rest of this presentation. However, when you compare that general population to the burn patient population specifically, the burn patients are at an even higher risk. And to help illustrate that point, I have Wirchow's triad listed on this slide. So for the majority of patients admitted to the hospital, they generally express 1 to 2 of these 3 characteristics. However, most of the burn patient population will generally express all 3 of these characteristics. So epithelial damage, endothelial damage, and stasis of blood. So in order to help manage this increased risk of VTE development, the most recent CHEST guidelines, actually there's some literature out there that also supports the use of heparin-based products. Most of the literature actually supports the use of enoxaparin over unfractionated heparin. So at Vanderbilt University Medical Center, we have a 25-bed burn intensive care unit. And what we have done is implement a standardized protocol at this institution to help manage those patients at an increased risk of VTE development. Illustrated on this slide is how we characterize many of these patients. And so depending on the category that you fall into, will depend on not necessarily the medication that you receive, but whether or not you will receive monitoring while on enoxaparin. So for example, our protocol actually states that all burn patients admitted to our intensive care unit will receive enoxaparin 30 milligrams subcutaneously within 24 hours of admission. However, for those patients that actually fall into the very high risk category, they will not only receive enoxaparin, but they'll also receive anti-10A monitoring and then titrate the enoxaparin to a goal anti-10A level of 0.2 to 0.4 international units per mil. Now, there are a couple exceptions to this rule that I do want to let you all know. So the first exception is if a patient has greater than or equal to a BMI of 40 kilograms per meter squared, they will, instead of receiving 30 milligrams of enoxaparin, receive 40 milligrams of enoxaparin twice daily. And the other exception to this is if a patient comes in and has renal impairment or develops renal impairment while in the hospital, which is defined as an increase of serum creatinine of greater than 50%, or a creatinine clearance of less than 30 milliliters per minute. They may be renally dose adjusted to 30 milligrams daily of enoxaparin or switch to subcutaneous heparin 5,000 units every 8 hours. So the method for this analysis, it was a single center retrospective observational analysis, and it looked at a 5-month time frame since the beginning of implementation of this protocol from March 2018 all the way through July 31st, 2018. And we included patients admitted to the burn intensive care unit, or BICU, for greater than 48 hours due to a burn injury. The primary outcome we wanted to look at was the percent of adherence to this protocol, with the secondary outcomes being reasons for non-adherence, and then also rates of VTE events. So the primary outcomes, which are detailed in Table 1, however, overall, this patient population was generally representative of the majority of the burn patients that we'll see in the burn intensive care unit. And then Table 2 actually details the characteristics of our highest risk patients, so those with a severe burn injury. And in this study, we had about 1/5 of our patients fit that category. And then also patients at highest risk are those with 180 kilograms or more in terms of body weight, or a BMI of greater than 40 kilograms per meter squared. And we had less than 10% of those patients represented in this sample. Overall, our compliance with this protocol was about 77%. And in terms of reasons for non-compliance, which are detailed here in this table for your information, however, the main reasons were incorrect frequency or dosing of enoxaparin, or no anti-10A levels were actually obtained whenever it was indicated per the protocol. Of note, sometimes patients were non-adherent based off a lack of weight or height recorded in the EHR or electronic. And in terms of rates of VTE events, we had no pulmonary embolisms occur within this 5-month time frame. However, we did have 1 deep vein thrombosis occur. Again, just some more secondary outcomes. So for anti-10A levels, we actually had 2 severely burned patients and 1 patient that had a body weight of greater than 180 kilograms not receive anti-10A monitoring. And then we actually over-monitored about 5 of our patients whenever anti-10A levels were not indicated. And then in terms of those patients when anti-10A levels were indicated, over half of those actually required an increase of their enoxaparin dose. So in conclusion, at this academic medical center, we did implement a standardized VTE pharmacologic prophylaxis protocol. And based off our compliance rate, which again was about 77%, we do have some opportunity to improve our compliance. And prior to this new protocol being implemented in early 2018, we did have an older protocol, which was analyzed in 2016. Some key differences between this older protocol and this new one was the older protocol at the time of review in 2016 had already been in place a few years, and there was some differences in terms of dosing, monitoring, and the frequency of the patient receiving enoxaparin. However, based off that analysis, our compliance was actually a little bit lower than in 2016. So thank you all for your attention, and at this time I'll open the floor to any questions.
Good morning. First, I'd like to thank the Southern Region Burn Conference Committee for allowing me to present our research today, and thank you to Dr. Smith and Bailey for moderating this session. My name is Andy Hess, and I'm a medical student from Texas Tech University Health Sciences Center, and today my presentation is over tube feeding through surgery and its impact on glucose control in burn patients. I have no financial relationships to disclose. A little background and introduction into our study. Of course, nutritional support is vital to the recovery of burn patients. They're extremely catabolic in the days following their injury and hypermetabolic, oftentimes requiring double the baseline caloric needs. To meet these high metabolic demands, we frequently provide these patients with enteral nutrition. However, as many of you know, despite our best efforts, we don't always end up providing them with as much as nutritional support as they need, for various reasons, such as their feeds getting stopped for surgery, for imaging, to go down to therapy, etc. Enhanced Recovery After Surgery, or ERAS, is a set of patient-centered, evidence-based protocols that the multidisciplinary surgical team implements throughout the patient's stay, from pre-op to post-op care, in order to reduce the stress of surgery, improve the body's physiologic responses, and enhance the recovery of the patient. Interestingly, there are studies that have been done, particularly in European countries, focusing on preoperative carbohydrate supplementation, which is part of the ERAS protocol. In these cases, they demonstrated earlier recovery of GI function and improvement of glucose management, especially in their diabetic patients. Patients at the Timothy J. Harner Regional Burn Center and ABA-verified burn center in Lubbock have been enterally fed up to and sometimes even through surgeries in certain cases since 2014. There are a variety of reasons feeding up to surgery is not done typically, including the risk of aspiration due to contents in the GI tract. But in these burn patients, we felt that feeding them up to and through surgery was more beneficial and outweighed the risk of those in certain patients that we had. This didn't mean that all of our surgical burn patients got this continued enteral feeding, and I'll get into which of those patients met the criteria in a couple of slides. Based on this background information, we created a study to assess how perioperative enteral nutrition affected the postoperative blood glucose levels in these surgical burn patients. We did this by investigating the blood glucose levels in these burn procedures that received the continued enteral feedings up to and through surgery versus those who had the feeds withheld on the day of their surgery. We performed a retrospective chart review from January 2014 to December 2016. We collected data on surgical burn patients who, during their inpatient stay, had at least 2 surgical burn procedures, one of which had the patient fed up to within 4 hours of surgery and or through surgery, and then at least 1 procedure in which the patient had their feeds withheld greater than 4 hours prior to surgery. By doing this, we allowed each patient to act as his or her own control. It's important to explain why or in what circumstances we feed or do not feed up to the OR procedure. The criteria that allowed for this continued enteral feeding that we did included endotracheal intubation, in which the patient's airway was already controlled and protected, and the patient being kept in the supine position, thus minimizing the risk for aspiration. Should the patient not meet either of those criteria, they weren't candidates for the perioperative enteral nutrition up to surgery. We also categorize these patients based on diabetic status, including non-diabetic if they had no prior diagnosis or hemoglobin A1C less than 5.7%, pre-diabetic if they had a previous history of prediabetes or no previous diagnosis but elevated blood glucose levels and a hemoglobin A1C between 5.7 and 6.4%, and then diabetic if they had a previous history and diagnosis or no previous diagnosis and elevated blood glucose levels during their hospital stay with a hemoglobin A1C greater than 6.4%. We also collected demographic information, percent TBSA, surgical information, nutritional information, and then specifically for this study, the main points we were looking at were pre-op and post-op blood glucose levels and post-operative insulin requirements. Our main comparisons that we looked at were the percent change from those pre-op blood glucose values to the post-op blood glucose values between the fed procedures and those that had the feeds withheld on the day of surgery. We did this first looking at all the total procedures, fed versus unfed, and then grouping them based on diabetic status. It's important to note that when I show you these results, we looked at them based on fed versus unfed procedures, not fed versus unfed patients. We collected data on 32 patients with a total of 106 unfed and 92 fed procedures. Of those, they were broken down into 13 patients that were non-diabetic with 70 total procedures, 10 patients that were pre-diabetic with 69 total procedures, and then 9 diabetics with 59 total procedures. And here is a graph showing you the number of procedures based on diabetic status. The black bar indicates the number of pre-diabetic patients, The black graph shows the non-fed patients and procedures, whereas the gray bar shows the fed patients and procedures. And as you can see, there's pretty comparable numbers of procedures based on diabetic status. These next 4 slides are our main results. They represent the percent change in blood glucose levels from 24 hours pre-op to various times post-op that you can see labeled at the bottom of the graphs. For example, here is 12 hours post-op and 24 hours post-op. Again, the black bars indicate the unfed procedures and the gray bars indicate the fed procedures. This graph shows the overall results from all fed versus unfed procedures prior to basing it all on diabetic status. The first set of bars show that from 24 hours pre-op to 12 hours post-op, the unfed procedures had a percent increase of 18.8%, while the fed procedures only had an increase by 2.5% in the blood glucose levels. And the second set shows that from 24 hours pre-op to 24 hours post-op, the unfed procedures had an 8.4% increase in blood glucose levels, whereas the fed procedures had a 2.4% decrease in blood glucose levels, meaning that the post-op blood glucose levels average lower than the pre-op blood glucose levels. Both of these differences in percent change between unfed and fed procedures from pre-op to 12 and 24 hours post-op were statistically significant. Here we have the non-diabetic group with percent changes from 24 hours pre-op to initial 6, 12, and 24 hours post-op. Except for that initial first set of bar graphs, the unfed procedures had a higher percent change from pre-op to post-op blood glucose. In comparison, the fed procedures in gray had relatively lower percent changes in blood glucose from pre-op to post-op. And our numbers looking at this, these differences trended towards significance. Here we have the pre-diabetic group. As you can see, the unfed procedures have higher percent change from pre-op to post-op blood glucose in the black. And then all of the fed procedures in gray had decreased percent changes from pre-op to post-op, meaning that the average post-op blood glucose levels were lower than the pre-op blood glucose levels. And of note, the values were statistically significant and lower between the fed and unfed procedures at the 12 and 24-hour post-op periods. And then lastly, we have the diabetic group. Here we see the percent change from pre-op to post-op in the fed procedures in gray show a little bit more variability, especially in that initial and 6-hour time periods, and then they decrease at the 12 and 24-hour periods. Our best explanation for this is that while our anesthesiologists are definitely getting more comfortable with us feeding patients up to and through surgery, especially in the diabetic patients, there's a number of anesthesiologists that still don't feel very comfortable continuing the insulin therapy intraoperatively or managing the hyperglycemia or rising blood glucose levels during surgery for risk of hypoglycemia. And then so in this study, these patients may have gotten that continuous enteral nutrition up to and through surgery, but did not receive the insulin management that correlated with it during surgery, and then didn't get it until postoperatively, which led to these higher blood glucose levels. In conclusion, controlling blood glucose ranges postoperatively is a critical goal to help us ease the burden on the body that's been associated with superior patient outcomes. This retrospective assessment of the impact of enteral feeding up to and through surgery on glucose physiology demonstrates that glucose management post-op is better when the feedings are continued, and these findings mimic those that we saw in the ERAS protocols showing improved glucose control. It would be difficult to name a patient population where improved glucose control is more important than those patients with these burn wounds. And so certainly this study supports the use of liberal feeding around operative procedures and is worth further investigation. Thank you very much.
Well, good morning. My name is Eduardo Navarro. I'm a research coordinator with the University of Florida College of Medicine, and I want to thank SMA and Dr. Smith and Dr. Bailey for moderating this lecture. Here are the disclosures for myself and Dr. Carson, my mentor. Now, split-thickness skin grafts at our burn unit follow the traditional protocol of being dressed with an inner non-adherent liner. Then this is covered with gauze and then a bandage to secure the graft in place. Now these dressings are then taken down all the way to the graft, starting post-op day 3 and then daily afterwards. Now this traditional method, of course, brings some drawbacks. Some of these drawbacks mostly revolve around these dressings having to be stripped all the way down to the graft, and these can be very painful. They really require IV narcotics for our patients to handle, and they have to be done in a semi-sterile field by a person who is knowledgeable about the dressing changes. Now, this method is sometimes not possible to be done at home by maybe the patients or caregivers who are helping our patients, and therefore our patients have to stay in the hospital and increase their length of stay. Daily stripping of dressings all the way to the graft also disturbs the graft, potentially causing some degradation or any contamination since the graft is exposed to the environment at every graft change. Most importantly, there is pain associated with the dressing population, which is what we ultimately would like to reduce in our patient population. With that being said, what do we want from an ideal dressing? So what does this mean? We want a dressing that, one, protects the graft from the outside environment. We want a dressing that stabilizes the graft, and a dressing that simplifies very much so the process of dressing changes in a manner that we are reducing frequency. We're making it easier to be done by not only the staff at our burn unit, but also our patients or any caregivers helping them after discharge. And ultimately, I want to reinforce also that we want these dressing changes to be very much less painful. In other words, we don't want anyone touching our grafts. We want the graft to stay by itself, have a barrier between that, the outside environment, as little manipulation as we can. Taking these factors into consideration, we investigated a Plm dressing, which I'll be referring to for short. It's a polylactate membrane, which is a bioabsorbable lactate copolymer that is generally used in the management of partial thickness burns. This is second-degree burns or donor sites. And this dressing mimics the natural epithelium, and it's very permeable to exudates while creating a protective coating around the wound. It has what we like to call a dual phase plasticity that conforms to the wound on contact with heat and moisture. So this film, which we can see here on the right side, it's a very crisp film when taken out of the package. Now, when it's applied to an epithelialized tissue, being a wound bed, it adheres to it and really sticks to it, making a sort of cover over it. And when you're putting over it, it sort of melts on top of it. And by that, it's contouring to the body part and really becoming one with the wound. On the right, we can see that it's a very porous material. Now, this dressing has its advantages, and some of the previous studies describing the use of this PLM is a way of protecting it as it creates a barrier between the wound and the environment, which is some of the factors that are looking for an ideal dressing. This barrier also allows for easier dressing changes, which reduce the pain and protect the wound. And other clinical outcomes that have been seen in previous studies are that patients are describing increased pain or decreased pain ratings, increased satisfaction, and there is a reduced time to heal. Here on the right, we see in the top part above the arrow that the PLM dressing is really adhering to the wound and not to the bottom part, which is the healthy tissue. With that being said, we thought, what else could we do this? Is there any novel application that we can start using other than just using it on a wound bed? With that, we thought about meshed autograft. Now, meshed autografts not only are used as our cornerstone for treating burns, but they also contain open interstices, which are the holes inside the mesh all throughout it. So we thought maybe we can use this as a way to really secure the graft in place. With that being said, we started using it, and we started seeing that it's really providing a mechanical stability to the graft by eliminating the shear forces. Here what we can see is that the PLM dressing, it's really going down into the interstices and sort of binding or melting towards the dermis and creates sort of a bridge in between all of them that really locks into place the mesh and helps it from any movements. We began using this dressing as an alternative to conventional dressings for mesh grafts. And with that, we decided to perform a retrospective Chart 2 IRB-approved study looking at infection rate, graft loss, need for regrafting, and of course, readmission. Now, we identified patients from one of our attending surgeons' postoperative logs who had used this dressing between the time frame of April 2018 to March 2019. Now, when using this graft, we ended up seeing that we started using a very minimalistic approach, starting from smaller wounds all the way to bigger wounds, and this liner is placed directly on the graft in the operating room, and we saw that we don't need to secure it with any staples, any glue. We were confident that it will really stick into it. Now here we can see it in action, mostly on the picture on the right. We can see that it's really sticking or melting into the wound, and we can also see the meshed pattern where it's also sticking into each of the interstices. Now, the outer layer is the only part that is removed from this. That is the benefit that I really want to emphasize. We're only changing the outer gauze and really leaving the inner part left by itself. So every time that there's a graft changing need, we don't have to be removing all the way and stripping it down all the way to the graft. We only have to do the outer part. Now this inner layer stays in place all the way up until follow-up, where it starts being absorbed by the body, or some of it is just peeled off. Some of our benefits is that the graft is protected at all time and there's no need to take it down, and with that being said, there is less pain at every dressing change. Some of our cases that we want to see here are, this is a second-degree burns, and post-op, it's also looking really good. A second case, we can also see another second or partial thickness burn on the foot, and all the way we followed it up to 5 months, and it also looks really well. We did a total of 22 patients, and once again, we started with the smaller ones, we moved all the way to the bigger ones, and we started being a bit more confident. And what we looked at is from our 22 patients at discharge, there was no graft loss. And then during follow-up, we saw in a total of 17 patients that we followed up, there was a complete healing of the graft, and we lost 5 to follow-up. There was no need for regrafting, readmissions, and there was no graft loss. But we did have 3 patients that reported minimal graft loss, but it healed without any intervention. So in conclusion, dressing is a very viable option for covering meshed autografts, And with that, we did have some limitations with our study, just being that we were not able to assess pain or patient satisfaction, and we also had a very limited sample size and the 5 subjects to follow up. With this being said, we would like to continue in a prospective randomized study evaluating PLM, or this PLM dressing, over our grafts to assess pain, patient satisfaction, infection, and graft loss. I would like to thank the burn unit at the University of Florida for helping with my study, and Dr. Smith and Dr. Bailey for moderating. Thank you.
Hello, I'm Catherine Schubauer. I'd like to thank the Southern Region Burn for allowing me to present today. I have no relevant financial disclosures. So in 2017, the opioid epidemic was declared a public health emergency. Since 2000, deaths have continued to rise at an alarming rate, inciting responses from local, state, and federal governments. Efforts have primarily focused on 2 major goals. The first being to limit the amount of opioids provided. For example, guidelines such as those implemented in Ohio only allow 7 days and 30 morphine equivalents per day to be prescribed. And then secondly, many groups have been focusing on looking at different adjunct pain management strategies to decrease the consumption of opioids, such as nonsteroidals or gabapentin. And specifically, Dr. Zhang's group out of Nationwide Children's Hospital has been examining the utility of using virtual reality to control burn pain in children. And our groups began collaborating with the ultimate goal of using this VR in adult burn populations. But there are a lot of challenges faced with adult burn populations that we don't see in children. For example, the perception of pain is complex. Patients may self-impose limits of pain tolerance, develop learned expectations, or readily adopt learned behaviors that confound pain management and are less common in children. When looking at adjunct therapies such as VR, patient buy-in is essential to its success. So we really need these patients to want the VR to work for them. As the VR study was being designed, it became apparent that we may need to introduce some kind of incentive, financial or other, to encourage adult burn populations to want the VR to work for them. And for this reason, we sought to study the impact of financial rewards on opioid consumption. So we had 2 main objectives. The first being to determine the impact of financial incentive on pill-taking behavior, and the second being to explore any impact on function or disability from offering a financial incentive to consume less opioids. So we enrolled adult burn patients presenting to the Ohio State University Burn Center with thermal injury to the upper extremity or hand. This was a 1-to-1 randomized study. No buyback and buyback were our 2 randomization groups. Both groups received a $25 gift card for completing a pill journal where they recorded the date and time of each pill that they took. And then the buyback group also received an additional incentive to flip for a $10 gift card for each pill that they returned. Those pills were put in a DEA envelope and shipped off after their appointment. We had an enrollment goal of 30, 15 in each group. This was calculated based on a power calculation to detect a 1 pill difference between groups. So again, we enrolled upper extremity burns. We excluded patients with chemical or electrical burns. We enrolled patients who were only inpatient for 3 days maximum and who presented to our outpatient clinic within 4 days of their initial injury. We also excluded patients whose pain could not be managed via the Ohio guidelines of 5 milligrams of oxycodone every 6 hours for 7 days, or patients whose management didn't require opioids at all. So our outcome measures. We looked at grip strength and quick dash. The quick dash is an 11-question assessment of functionality for the disability of arm, shoulder, and hand. It has questions such as how difficult is it for you to open a jar over the course of the last 7 days. We also looked at grip strength, which is the difference between hands. Literature currently states that the difference is about 10%. We saw no significant difference in age, sex, race, education, percent employment full-time, or total burn surface area. And then our average total burn surface area was 2.4%. So looking at our assessments. Patients were asked to complete their one functional assessment, the quick dash, thinking back to the 7 days prior to their burn so that we could get a good baseline function. We saw an increase in quick dash score in both groups from day 1 to day 7 as a result of injury. However, we saw no significant difference in functionality between the groups as approximated by that quick dash score at day 1 or at day 7. Looking at grip strength, we calculated the difference in grip strength between hands at baseline and follow-up. We saw a non-significant trend that the difference decreased from day 1 to day 7, indicating increased healing. And then again, we saw no significant difference between our groups at day 1 or day 7. So looking at the number of pills that these patients took, we saw no difference between our groups' use of pills on average. Buyback group used about 2.1 pills per day, and the no buyback group used about 2.6 pills per day. So both groups used significantly less than the 4 pill per day guideline. That p-value was about 0.002. On average, the buyback group used 13.9 of their 28 pills, and the no buyback group used 17.3 of their 28 pills. So what conclusions can we draw from this? We saw no significant difference in functional assessments at 1 week. We also saw no significant difference in overall pain or total pills used between groups as a result of the financial incentives that we provided them. In the subpopulation of burn patients, it appears that the Ohio guidelines of 5 milligrams of oxycodone every 6 hours for 7 days appears to be adequate in controlling the pain in this acute population. Additionally, patients in the buyback group returned on average 12 pills of their 28 pills. Current CDC estimates state that about 58.5 opioid prescriptions are awarded for every 100 US citizens. So that equates to about 2 billion unused pills per year if we extrapolate that data. So I will go ahead and take questions now. Oh. Sorry, I missed a slide. Limitations of this study include our sample size. Because patients took far less pills than we would expect, our power calculation would be inadequate. We might have to revisit that. We did also have patient follow-up, which is expected with this population, and our response bias might have been introduced in our non-buyback group because we didn't count their pills. That will be addressed in the next phase of the study that's going to be conducted at Wake Forest. Now I'll take questions.